So now I'm talking with Charles Hewitt, who's the Director of HIE Program Management here at Rhode Island Quality Institute in Current Care. Thank you very much for taking the time to be with us today.
Glad to be here.
We're mostly going to talk about direct and the direct services you provide, but before we do that, as the students are going to learn in the next lesson, patient privacy is always a concern when health data is being utilized.
Absolutely.
And can you briefly tell us what patient privacy model you use? Students are going to learn about the various models later on.
Sure. In Rhode Island is a so-called opt-in state. In our case, the opt-in is very strict. We, as an HIE, we cannot even see your data until you have given consent for us to see it, to collect it. When you do give your consent, in the Rhode Island model, you give consent for all of your data, including sensitive data like substance abuse treatment, for example. You also, when you give consent, you're consenting to who can see your data. And you basically have three choices. The first choice is anyone that's treating me, providing treatment or coordination of care. The second choice is only in an emergency. Only in an emergency will I allow anybody to see my data. And the third choice is just for these providers. And you actually list them on the form.
Well, that's interesting. Do you know off the top of your head what percentage of patients fall into each bucket?
Absolutely. About a little over 95, 96%, that range, select the first option, all of my providers. About 2 to 3% select emergencies only, and about half of 1% select the third option, just these providers.
Just skipping ahead for a second, what's being avoided here, which we'll discuss a lot in a lesson later on in the course, is the issue of allowing patients to select which data they want to share, which is very hard to do.
Absolutely. In fact, it's a very challenging topic, this so-called segmentation. In Rhode Island, the law is all of your data. And that was basically the result of a compromise between the consumer advocates that wanted to be able to hold certain data back and physicians that said I need it all in order to provide effective treatment.
Well, data segmentation will be a topic we look at in some detail later. The second thing, and really the primary focus, I hope, is for you to give us more detail. Laura and I talked briefly about direct and the idea that it's used as a service, but can you give us more detail about the sorts of things you're doing with direct?
Sure. We're doing two things with direct. One is on the inbound side, where we are collecting data from data sharing partners. We use direct to get feeds of continuity of care documents, CCDs.
Students know what those are.
From the instance of the EHR that they happen to be using. So if they're using, for example, Allscripts, we worked with Allscripts so that Allscripts would generate a proper CCD, attach it to a direct message, and send it to the current care gateway, where it is checked to see whether that patient has consented or not, and if the patient is consented, it flows on into current care. Otherwise, it's blocked at the gateway.
And I understood from chatting with Laura that process is fairly automated at the provider end. The provider doesn't have to do that every time.
Very much so. In fact, it's automatic. Once it's set up, when the provider takes a certain action like lock up the record after an encounter, the system automatically does all this process of creating the CCD and sending it off to current care. It's all completely invisible to the practice.
And I also know from talking to Laura that you have a fairly large number of EHR systems implemented here in Rhode Island. Were the vendors pretty amenable to doing this?
I would say some were, some weren't. Part of the problem is that the vendors have a lot of priorities, especially meaningful use. And so implementing this feed for the Rhode Island HIE in many cases has been way down the list, and we have to basically encourage the practices that want to send us data to go back to their EHR vendor and tell them that I need you to do this for me.
So what about some of the services go the other way? You've got the data now.
I've got the data now. Now on the outbound side, the major service we provide using direct are alerts. There are three kinds of alerts. One is a so-called hospital alert. In that case, we receive a ADT transaction from a hospital. You've been admitted, say, to the ER. And in that transaction has been entered the identification of your primary care physician. We look up that primary care physician, and if they're subscribing to alerts, then we create a notification message, and it's a very simple email type message. Very little information in the message itself, and send that off to the practice. Typically, that message is received in an inbox that's being monitored by a nurse case manager, and that person will decide what to do with the message. There's a link in the message to current care, to the current care viewer, so if they want, they can go in and review what the ADT was in detail, along with all the other information that's in current care.
What is the adoption of these alerts? I mean, what?
Right now we have here in Rhode Island, and we're a small state,
Yes.
But we have 150 practices that have subscribed, and they represent about 400 to 500 subscriber providers, individual people. And we generate about between 5,000 and 6,000 alerts per month to that group.
This has been fascinating. Thank you very much for taking the time to do
You're
it.
welcome, Mark. Nice to speak with you.